Okay, good afternoon, everybody. I'm Dr. Swaleha, and today we are going to discuss the very famous drug sertraline. So, from a historical point of view, sertraline was the second SSRI to be brought into the market. So, Kenneth Ko, a chemist, was looking at the structural features of potent and relatively selective uptake inhibitors. So tamitrelin derivatives were tested and sertraline was picked up from this group because of its selective and potent nature. Thereafter, it was patented by Pfizer, and then research was carried out, and it was actually found that it was quite effective, and hence it was approved by the UK FDA, and then it entered the market. It was investigated and adopted for many uses. Uh, During the early part, it was one of the only SSRIs in the market, and slowly it started becoming very common, and now it is the second most popular psychiatric medication which is prescribed. So we should know about this drug in detail. So the indications for sertraline are major depressive disorder, premenstrual dysphoric disorder, panic disorder, post-traumatic stress disorder, social anxiety, obsessive-compulsive disorder, and generalized anxiety disorder. Out of these, the bold ones are FDA approved. Now, the mechanism of action, it acts on a number of receptors, but it basically boosts the neurotransmitter serotonin, and it blocks the SERT transporter, that is the serotonin transporter. And by blocking this, it blocks the reuptake of serotonin. It also acts on other receptors like 5-HT1A receptor, where it desensitizes the serotonin receptor, and it also is presumed to increase the serotogenic neurotransmitter. Apart from serotonin, it has some ability, a weak ability to block dopamine reuptake inhibitor also. So it might increase the dopamine neurotransmission also. Another receptor on which it acts is the sigma 1 receptor. The clinical relevance is unknown, but it acts on all these three receptors mainly. Pharmacokinetic point of view, the parent drug has a long half-life of approximately 26 hours. It is also metabolized and methylated in the liver. The metabolite has a longer half-life, even though it is not that effective. But the metabolite is also shown to be there in the body for almost 100 hours. Then it acts on two enzymes, CYP2D6 and CYP3A4. At both these enzymes, it acts weakly, especially at lower doses. So drug interaction is relatively less because of these actions. Now let us look at a few studies. So a review compared sertraline to other antidepressants, and they studied almost 29 researchers, which included more than 10,000 participants. And this was done to first see the efficacy of sertraline and then see the acceptability also compared to other antidepressants, and of course the adverse effects of sertraline in comparison with others. So what this study found was that yes, it was quite efficacious and acceptable also, but the only problem was that compared to all other medicines, sertraline patients on sertraline experienced higher chances of diarrhea. So SSRIs we know are very common in causing GI side effects, and this particular GI side effect was more common in sertraline compared to all other drugs. Another study studied the effect of sertraline if we gave it in patients with acute MI or unstable angina. So major depressive disorder, it occurs very commonly in acute coronary syndromes, and it increases the risk of morbidity and mortality. So that is why this study was done. Almost 369 patients were studied and HAM-D was applied. And it was seen that after 2 weeks and after 24 weeks, there was a rapid improvement in HAM-D scores, and it was found to be safe and effective for treatment of depression occurring in patients with MI or unstable angina. So this was found that it can be safely given in cardiac patients also, which was not true especially with TCAs. So this was found to be quite safe. Another study was done to see its effect in patients with congestive heart failure. So again, they studied the safety and efficacy in treatment of major depressive disorder in patients with CHF. So mostly it was patients who were more than 45 years of age with current major depressive disorder and chronic systolic heart failure. So what was found was that the scores on HDRS, which is again a measurement of the depression, it was seen that from baseline there was definite improvement in the scores, and they also compared the composite cardiovascular score. So it was found that improvement was seen in the cardiovascular score in 40% of patients. Unchanged score was there in 29.5% patients, and some worsening was seen in 29.9% of patients. So it suggested that the scores decreased, and even the composite cardiac score was mostly favorable in most patients. So again, the mortality which is there in depressed patients with heart failure can be elevated by giving sertraline because it does not adversely affect the outcomes, and it can be used as an appropriate therapeutic strategy, especially in patients in whom non-pharmacological interventions have not worked. So these patients are good candidates to start sertraline. Then another study which studied the effect in patients with Alzheimer's disease. So again, if a patient with Alzheimer's disease developed depression, can we give sertraline? That is what was studied. So there were 22 patients, 12 were given sertraline and 10 were given placebo. This was studied for 12 weeks, and it was seen that patients who were given sertraline had significantly greater mean declines from baseline on the Cornell scale for depression, which is seen in dementia patients. So by the end of third week of treatment, there was definite decline in score. So depression decreased in these patients of dementia. So it was then concluded that sertraline is superior to placebo in reducing depression in patients with Alzheimer's disease who suffered from depression. So again, these are again a particular category of patients in whom we can think of starting sertraline. Then similarly, in patients with mild traumatic brain injury. So patients who have a history of mild traumatic brain injury and then thereafter if they develop depression, again it was studied that can we give sertraline. So Hamilton rating scale for depression was applied and 87% patients had a decrease in score of more than 50%. So these were the response category of patients. 67% of patients achieved a score less than 7. So this was remission. So both response and remission was seen by 8 weeks of starting sertraline. So hence it was concluded that there was statistically significant improvement in psychological distress, anger, aggression, functioning, and post-concussive symptoms with giving treatment with sertraline. Now, this is another study. This study was to see if sertraline improves the executive functioning in patients with vascular cognitive impairment. So, EXIT 25 is again a scale which specifically measures their executive functioning. So it was seen that the scores improved significantly. So 57.1% of these patients experienced a clinically meaningful improvement in executive control, and 34.3% of patients achieved remission. So this suggested that sertraline may have both statistically and also clinically meaningful effects on executive functioning in patients with ischemic cerebrovascular disease. So this was again a particular category of patients which was studied, and improvement was found with sertraline. Then again, a case report of two 80-year-old patients was done. These patients had vascular cognitive impairment, and as you can see, patient 1 at baseline the MMSE score was 30 by 30 and the exit 25 score was 22 by 15. After starting sertraline 150 mg per day, there was improvement in exit 25 score. It went from 22 to 16. And in the second patient again, after starting 150 mg of sertraline, the exit 25 score again was lesser. Now, another classification of patients in which we can use sertraline is PMDD. So, premenstrual dysphoric disorder. These patients have symptoms which develop usually around their menstrual cycle. So, this study was done to see if continuous versus the intermittent dosing of sertraline for patients with severe PMDD. So intermittent dosing means giving the dose just before menses or during the luteal phase of menstruation. So again, rigorous scientific examination was done, and significant improvement was there in PMS symptoms. And as you can see, pre and post menstrual symptoms over 3 cycles were studied, and there was improvement with sertraline. Full cycle and luteal phase dosing both showed similar improvement. So yes, there was improvement as you can see in this chart. So it was effective as a full cycle dosing also and in luteal phase also. And here also you can see symptoms like irritability, mood swings, anxiety, depression, feeling out of control. These symptoms definitely improved. Physical symptoms like breast tenderness, swelling, bloating, these symptoms also improved compared to the placebo. So placebo is the green colored, and the blue and red are sertraline luteal phase and full cycle respectively. So both the blue and red, as you can see, are quite similar. So again, improvement in all scores was comparable, and significantly more subjects uh, in all these cases showed improvement compared to the placebo. So it was concluded that both these dosing regimes worked, but of course, if we give premenstrual dosing, then there is less exposure to drugs. So even though both these regimes are effective, side effects might be lesser if we give a premenstrual dosing. So it is again an important factor to consider, especially when we are thinking of giving these in our clinic. So again, premenstrual dosing might decrease the side effects. Now, clinical subtypes of premenstrual syndrome and their responses. So, secondary data analysis was done for women who were diagnosed with PMS or PMDD. There were 3 types identified: psychological, physical, and both. So, scores for each symptom and the total score was compared from baseline, and then it was analyzed. So this was what was found, that only the mixed symptom subtype significantly improved with sertraline compared to the placebo. Strong improvement in mixed subtype was driven by the psychological symptoms. So as expected, the psychological symptoms improved more. So majority of women were distressed by both psychological and physical symptoms. And the two physical symptoms which improved with sertraline was swelling, bloating, and breast tenderness. And the premenstrual symptoms improved significantly related to the placebo, whether the diagnosis was PMS or PMDD. So again, another study showed that symptom onset dosing of sertraline for these PMDD patients. So they showed that either as a daily treatment or restricted to luteal phase, both was studied, but the symptoms were also present for 7 to 4 days before the onset. So that is why, again, giving treatment during this time was better. So, women with PMDD may benefit from the treatment limited to interval between these onset of symptoms and the first few days of menses. And if we abruptly stop the treatment, there was no increased risk of discontinuation symptoms also. So we can very safely give these medicines only during the luteal phase. Now coming to panic disorder. So it is a common anxiety diagnosis. It has prevalence of 3 to 4%. And sertraline, when it was given in treatment of panic disorder, it was again showed to be very good, and there were excellent results found with this. So 239 patients were screened, and out of this, 225 were taken in the study. Paroxetine, we know, is a very effective drug for panic disorder. So sertraline was compared with paroxetine. 112 patients were given sertraline, and 113 patients were given paroxetine. Out of this, there were some dropouts, and in the end, 85 and 81 patients were compared. So primary analysis showed a non-inferiority, that is, it was similar. So sertraline and paroxetine both had similar scores on the panic and agoraphobia scales, and secondary measures like panic attack frequency and the clinical global improvement measures were also done. And as you can see here, almost similar results can be seen with sertraline and paroxetine. And again, the change in panic and agoraphobia scale and the total score, as you can see, again, sertraline and paroxetine. With sertraline, it is lesser, but paroxetine being the gold standard, it showed better improvement. So yes, they are equally effective across all the measures, but treatment with sertraline was significantly better tolerated because it had lower side effects, fewer discontinuation also, because discontinuation is something which is seen very commonly with paroxetine. And again, lesser weight gain because anti-cholinergic side effects are again comparatively lesser with sertraline. So improvement in panic anxiety was maintained during the gradual tapering, while gradual paroxetine taper was uh, associated with significant worsening in symptoms. Again, another study studied the 250 patients who were randomized with 12 weeks of placebo either placebo with sertraline, and with CBT. So this was studied, and core panic symptoms were studied, like panic attacks, anticipatory anxiety, agoraphobic avoidance, and dysfunctional cognition is also was studied, and then disability and the clinical global improvement was studied. So the outcome was that sertraline with CBT produced significantly greater decrease in all the symptoms. Secondary analysis also showed at 12 weeks sertraline with CBT had far better improvement. So yes, sertraline alone is not as effective. Rather than we should try to give sertraline along with the CBT treatments also in patients with panic disorder. Now coming to PTSD, post-traumatic stress disorder, again very common, 2.2% of population, 7.7 million people suffering from these conditions. So again, 70 veterans were studied, and they were given sertraline of ranging from 50 to 200 versus placebo for 2 weeks. So again, scales were applied, and the results which were found was that both the IES, our total scores, and the clinical global scores were significantly greater in sertraline groups compared to the placebo. The CGI mean endpoint score was significantly lower in sertraline, and the number of responders were also higher compared to placebo. Hence, it can be concluded from this study that sertraline is effective, safe, and tolerable for treatment of combat-related PTSD in veterans. Now, again, a lot of studies have been done. A few studies are here which evaluated the use of sertraline in adults with PTSD. So, all these studies showed that there was significantly lesser symptoms of PTSD when we gave sertraline to these patients. Lower relapse rates were also seen if we gave sertraline as a prophylactic treatment, and also it was seen that discontinuation rates were also lesser because of lesser side effects. It was well tolerated, and even patients having comorbid anxiety and depression also showed higher effective treatment with sertraline. Now, children were also studied who suffered from PTSD, and first double-blind placebo-controlled trial was done, and this was done in children and adolescents of PTSD, and 26 children were evaluated from 6 to 20 years, and 24-week study was done. Each child received sertraline, again ranging from 25 to 150 mg per day versus a placebo. The information collected was compliance with the treatment, the parental assessment of the children's symptoms and their functioning, and the child's self-reported symptoms also. So as you can see, compared to the placebo at baseline, these were the score at week 8, 12, and 24. You can see a gradual decline in the PTSD scores with sertraline, especially compared to the placebo. Both child rated and parent rated symptoms were found to be lesser. The parent reported symptoms showed significantly greater improvement in all three groups, as you can see here, compared to placebo. And hence it was concluded that sertraline can be effectively given in children also. So it was a safe drug for use in this population, particularly children suffering from PTSD. Now, another indication for sertraline is social anxiety disorder. So again, it is the third largest mental health problem with 7% of the population suffering from this illness. This study evaluated the pharmacokinetic safety and the clinical efficacy of sertraline to treat social anxiety disorder. So they found that the prevalence was 2.4% and higher prevalence when we look at the 1 year prevalence. So it was even higher. Uh, so it is again very, very common. And when we see the clinical efficacy of sertraline in social anxiety disorder, three studies were done. First study was a 12-week study with more than 400 patients. They found that there was a significantly more effectiveness with sertraline compared to placebo. Especially patients who had severe symptoms showed better improvement. The second study was a 20-week study with sertraline 50 to 200 mg. Again, they studied 200 patients and significant improvement was seen. So with sertraline 53% improvement versus placebo which showed only 29% improvement. A third study was a longer term study. It had 50 patients with 20-week study again compared to placebo. There was significantly lower relapse rate of patients on sertraline. So on sertraline, the relapse rate was 4%. On placebo, it was 36%. So very high, comparatively higher rates were there in placebo group. Now, in safety and tolerability, which is again a very important factor whenever we are prescribing any medicines. So, high compliance in treatment continuation rates were there with sertraline compared to other SSRIs. And again, like we had seen in pharmacokinetics, so the CYP inhibition, each SSRI has a particular profile. Sertraline is comparatively safer compared to fluoxetine and paroxetine because they have a stronger inhibiting effect on CYP. Sertraline, especially at lower doses, has a weaker effect. So again, no single SSRI was clinically superior as was found by this study, but sertraline was found to be the first choice for treatment mainly because of the low cost, but in general, all SSRIs were found to be superior. Now, OCD, again, 74 million people suffer from OCD. It's a very common illness. And sertraline, again, in children and adolescents with OCD was found to be very, very effective. So, almost like you can see, 74 children completed the study in sertraline group and 82 children completed the placebo group. And what was found that compared to placebo, that there were definitely the Y-box score was lower in the sertraline group of patients. So as you can see, with time the scores are decreasing, and at 12 weeks the scores are very, very low, especially compared to placebo, which is showing a higher score on Y-box scale uh, with patients on of OCD. So, sertraline was found to be safe and effective for short-term treatment for children and adolescents with OCD. And cognitive behavior therapy was also compared. So, it was found that sertraline is beneficial to patients who have failed CBT. So, this is again a particular category of patients who in whom we can give sertraline. Again, this was another study which showed a double-blind trial comparing sertraline with placebo at week 12 weeks and 52 weeks. So what was seen was at 12 weeks, yes, the Vibox score was low, but it was consistently low and it remained low at 52 weeks study also. So there is reasonable evidence of safety and tolerability of sertraline in long-term treatment of children and adolescents with OCD. Its effectiveness in pediatric OCD was sustained, so over 52 weeks also the Vibox scores were lower. There was enhanced with continuation of treatment. In non-responding treatment, clinicians can choose to administer a trial of pharmacotherapy, but beyond 12 weeks, if the patient has to respond, they will respond beyond 12 weeks. So this is the time period in which a trial can be given in children with OCD. So to summarize, it has a dual action with inhibition mainly on the serotonin reuptake, a less amount of inhibition on dopamine reuptake also, but mainly it acts by increasing the serotonin transmission in the nerves. Cognitive and affective flattening may theoretically be diminished compared to other SSRIs, mainly because of the dopamine effect. So its therapeutic value in major depression, OCD, social phobia, panic, PMDD, all these have been established by the studies. It can be a first choice in atypical depression also, because of its relatively weak effects on cytochrome P450. A tolerable profile was there compared to other antidepressants. It can be safely given, and if the patient overdoses also, it is relatively safe. A lot of studies have been documented that it has cardiovascular safety in myocardial infarction and angina patients. It can be safely given. Uh, Relatively safe in pregnant and breastfeeding women also. Women with PTSD and depression are found to be more better responding to sertraline compared to men. And of course, uh, because relatively less effect on prolactin, it is preferred in children, adolescents, and women also. So, with this, thank you so much for listening. I'll conclude my lecture and we can open this topic for discussion.